and welcome in this educational video, A Pain in the Neck. My name is Rob van Wessem. I'm a specialist in equine sports medicine and rehabilitation. I'm also specialized in equine medicine. I work in a practice called Equine All Sports Medicine Center in Mason in the United States, and I've written several papers and chapters in textbooks about back problems in horses and especially neck problems in horses. When we look at the anatomy of the neck, we have 7 cervical vertebrae, for sure a bunch of muscles, tendons and ligaments, some joints, a bunch of nerves, and the spinal cord. Don't worry, I have pictures to show you more about it. When we look at the anatomy of the neck, we can see here the 7 vertebrae, and they are a bit more different than we maybe think how they would be in the neck. When you look at the top of the neck here, you can see that the vertebrae more or less like halfway down, even a bit more lower into the neck. This picture shows you a couple of the muscles. There's also a tendon here attached, and it's all going through like tendon ligament all over to the withers and even then lower to the back. And then we have a couple of deeper muscles here. In this picture we see more of the muscle layers on the neck, and we see a lot of muscles are really just on the neck itself, but also muscle layers that attach to the shoulder blade and through the shoulder blade to the lower back. We also have some muscles that are attached to the front leg, and we have some muscles that are attached to the head. In this picture you can see a little bit more of the joints in between the different vertebrae. You see here a vertebrae, and then here this line. This is one of those facet joints. That's how they call the joints in between the different vertebrae. And then you have the last facet joint here that goes from the last neck vertebrae to the first thoracic vertebrae. What we see here is a stretched image of all the vertebrae. C2 means like it's the second cervical vertebrae, C3 the third, and so on. And you can see here those joints. The process of this C3 makes contact here with the other process of C2, and that makes one facet joint. And there is one on the left and one on the other side on the right. Well, where is pain in the neck coming from? The origin. We can have them coming from joints. Then we call it arthritis when the bone is involved. We call it synovitis if the inside layer of the joint, the synovial membrane, is involved, and capsulitis if the joint capsule is involved. We can also have tendon problems and ligament problems. When we have tendon problems, inflammation of the tendons is called tendinitis, and when ligaments are inflamed, it's called desmitis. We can also have pain from fascia. There are like little layers of stretched connective tissue, and we call that myofascial pain. For sure we have pain from nerves, and if the nerves are involved and inflamed, we call it neuritis. And when nerves are compressed and there's a lack of function, we call it neuropathy, meaning like really a problem with the nerves. And then we can have problems with the spinal cord. What kind of symptoms do horses show when they have neck pain? It's a lot. We can have loss of flexibility, stiffness in the neck, and as you can imagine, when you have ever had your own neck being stiff, quite often you have stiffness in the entire body. We can have problems in connection, making, if you ride, that the horse is certainly very loose or very heavy on the hand. We can have problems with lameness, stumbling. Quite often we see in neck problems, we see behavioral issues, running off, bolting, bucking is an option, rearing, stopping, and so on and so on and so on. The list is endless. When I was mentioning all the components in the neck and all the different components that are in there that can cause pain, you can imagine when we have so many causes, we have many symptoms, and unfortunately so many and quite often useless therapies. The most important part is find the cause, find exactly where the pain is coming from all those components, one or maybe a combination of them, and that process we call having a diagnosis. What kind of specific symptoms do we see with joint problems when there is damage to joint structures like cartilage, the joint capsule, or the synovial membrane? In general, it will be mild to moderate pain. There's quite often a loss of range of motion, so they're stiffer to the side in one direction or in both, or more to down or upward. and quite often with joint problems, it gets better after warm-up. We have to realize that joint problems are very common, and a lot of horses don't even have symptoms. And we can see on a lot of older horses on x-rays that they show signs of mild, even moderate arthritis without having any clear clinical problem with it. With tendon and ligament problems, we also quite often see mild to moderate pain, stiffness, loss of range of motion, and quite often stretching of that tissue is painful. And what we see with tendon and ligaments, it doesn't get better with warm-up. It doesn't change, or maybe sometimes even get worse. Especially when horses start to stretch more when they got warmed up, then symptoms of tendon and ligament problems sometimes become more obvious. With nerve involvement, we quite often have a very painful sensation in the horse. It's often a sudden onset pain, like an electrical shock, or stabbing pain, like they get stabbed with a knife. And the duration from the pain can be from a split second to really long, weeks, months. And you can imagine the horses that have that much pain are really in a bad shape. Nerve involvement quite often is unrelated to warm-up, and what we quite often see is sensory issues. They can stumble, they can be lame, they can have ataxia, because they don't really know where their legs are or where part of their body is. This picture was from a schematic picture from the human anatomy, but it's still nice to explain a couple of things. Shows you a couple of components I want to talk a bit more. What we have here in white is the vertebrae, with here the facet joint. Blue here is the intervertebral disc, and yellow, this white thing here is the spinal cord. The yellow thing around it are the meninges. You have heard from meningitis, that's when that's inflamed, but the meninges are like the little outside layer around the spinal cord. And what we see in between two vertebrae is an opening. We call that a vertebral foramen, and through that opening comes a big nerve. That's what we call the root nerve, and the root nerve is covered by a little bit of that, and the first like 1.5 to 2 inch of this tissue coming out of this opening is covered with also some meningeal tissue. And that's why a lot of the pain comes from when this joint opening, or this opening here, becomes too small because the joint gets bigger, or the bone changes, or the intervertebral disc starts to push up here, and then you get a compression of the nerve and a compression of that meningeal tissue, what's very painful. And the root nerve, the nerve coming from the spinal cord in between two vertebrae, the first area, the first 1 to 2 inches are really close to the joint structures. So depending on the position of the neck and how big and how large that joint is, that depends on how much space that nerve has, and if that is sufficient for normal nerve function, or that starts to compress it. This sketch shows you a segmental view through the vertebrae and the spinal canal. That's just like a slice through the horse. So we're looking at, like we were looking from head to toe, and then somebody made a slice of it. So what you see here in black is the top of the vertebrae, the body of it. This is part of the joint process. The green is the joint capsule, what keeps that fluid in this joint. This is the lower part of the vertebrae. In blue we have the spinal cord, and in blue we have from the spinal cord that root nerve coming out. In red, that's the meningeal tissue, what sits around the spinal cord in the spinal canal, and it goes around the first little piece of that root nerve. So you can imagine if this opening here gets smaller because this bone changes, or this opening here gets smaller because this joint gets bigger from bone or from soft tissue, then this nerve has not enough space. This slide shows you a couple of different neck positions, where more or less this is the normal position, and then the openings are quite often in between those vertebrae, the vertebral foramen, to have a normal opening. You can imagine when the neck goes really high up, quite often a couple of the openings here really get smaller, and maybe here too. And when the horse gets really down, like in a roll cur, you can imagine that especially here in this area, there's a lot of pressure on those openings to make them smaller. Just another picture to quickly go through a little bit of the anatomy. This is where the head is. The first vertebrae attaches to the back of the head. Then here we have the atlas, where a pin, like the dents, from the second vertebrae comes in, so this can rotate. That's why the horse can look sideways. And then we have all the other vertebrae with the openings here where we're talking about the vertebral foramen. In this picture of a real vertebrae, two vertebrae, you can see where they make up that facet joint. You can see that it's not a flat surface, but it's a little bit wavy shape, so it can move, slide. That's why we call it a facet joint. It can go in all directions. What we see here, this bumpy area, this is a little bit of like extra bone that has been formed from here to here, this edge, where the joint capsule sits. So you can imagine if that joint capsule gets thicker and you get some bone spurs in this area, then there becomes more bone here. What we see here, down underneath here, in this area, is where the vertebral foramen sits. Another picture of this facet joint space here. This is again that bumpy area with some extra bone spur. Here's where the joint capsule would go, and this is your vertebral foramen. So you can imagine if there's a lot of extra tissue here, it's not really compressing on the nerve, but if it's here in this area, then the root nerve doesn't really have a lot of space anymore. This picture, in a little bit different angle, shows you again that facet joint. This is your foramen. This is where the nerve comes through, and then it goes in a lower and an upper part. So you can imagine there's not a lot of space. So when this bone gets more, or this bone gets more, or the soft tissue that sits here swells, there's really not enough space for that nerve anymore. Okay, now to the important part of diagnosis. How do we find what's going on? We need a full workup. It's a clinical exam where we look at walk, trot, canter, a serpentine. We do flexion tests. We'll lunge the horse. Quite often we want to see the horse being ridden. We'll check saddle fit. We quite often do a digital gait analysis. All things to look as like how is the horse moving, and is there a lot of asymmetry in there that gives us an indication that something in the neck is going on. For sure, a good neuro exam, what takes quite a lot of time, but looks for reflexes, coordination, and the sensation of certain skin regions, or more or less more skin regions. The next step quite often is radiographs of the neck, and we quite often sedate horses for that, so that they stand quiet. What helps is when making only one picture per area and not more, because the horse doesn't move. It also, when the horse is standing quiet and stretches the neck a bit, we get better imaging. And what we always do is an ultrasound of the facet joints. First, just a normal ultrasound to look at how the facet joint, the soft tissue of the facet joint looks like. And then we do one with Doppler, where we can look at color, and color gives us an information of blood flow, and more blood flow around the facet joint, or especially very close to the capsule, shows us that we have a problem in that capsule, like inflammation. And a couple of other options we can use is EMG, where we stick needles in muscles and measure the signal from the nerve to the bone, to the muscle. We can do a bone scan, and we can do a CT. And they're all possibilities, but in general, they're more for very difficult cases. The things higher up, X-rays and ultrasound, quite often tell us a good picture of what's going on compared with the full workup. This picture shows you how we check the lateral flexion of the neck, and in general, when you ask a horse to flex sideways, it should be able to come with his mouth in the direction of his shoulder. What this horse shows on this picture is that he's not coming that far, and he starts already to rotate in his top of his neck, C1 and C2, instead of rotating, flexing the whole neck sideways. What clearly is a lack of lateral flexibility. And in this picture, I'm making the horse stretch up the neck and see if that's possible for him, and also look at the size of the area where the facet joints sit, and that's in this horse very visible here. If you stand here and you watch, you can see if this on the left and on the right more or less is the same size and the same shape. In this picture you can see clear muscle atrophy in part of the neck on the right side and on the left side. You can see on the left side it's maybe a bit smaller than this huge area of muscle atrophy on the right. What tells us that likely the muscle conduction here somewhere is more severely disturbed on the right side and on the left. This is a picture of an X-ray of the neck, like C3, C4, C5, and what you can see here, this is the facet joint, and one from the right and one from the left are just projected over each other. Here too, here too. This is the intervertebral foramen, and we can see that when we go down the neck, that gets smaller. That's normal. What we always look for is like the shape of the spinal canal. This is where the spinal cord goes through to, and it should have a nice smooth transition from one vertebrae to the next, so no steps in here. This is smooth, this is smooth, this is smooth. This is the area where the intervertebral disc sits, and they all should have more or less in all those vertebrae the same appearance. This radiograph shows you a little bit more of the facet joint, and here you can even see the facet joint opening, the joint space, and again very clear, obvious intervertebral foramen and your intervertebral disc. In this picture you can see on the circle here where I have my dot now, there are a couple of little fragments in the area of the intervertebral disc, what quite often is an indication that there are problems here with the intervertebral disc, while this here is clean. And you can imagine when the intervertebral disc here has problems, it's very close to the spinal canal, so if there is some swelling here or even some tissue from the intervertebral disc going into the spinal canal, we can have major neurologic issues. So X-rays are a good tool for initially looking at a couple of things, and in general when we do those X-rays we hope we don't find them so that we can go on with doing an ultrasound. I mentioned before on images how important it is to look at the congruity of the spinal canal, and what we can see here is that there's a little bit more of a little step in here. This vertebrae looks like this is where the vertebrae is, and this is where this vertebrae length more or less is, and they make an angle that's not completely normal. And when you look here, it looks like that's not very smooth, but there's a little step from here to here. So that's an indication for having some problems in the stability of the different facet joints, creating some steps in between vertebrae. Quite often this is called wobbler when there is instability, and what it quite often causes is compression of the spinal cord and quite severe ataxia. And this picture, what we can see here is that here is facet joint, and I hope you remember how this other looks quite nice and smooth and round. This is not round, there are all kind of little fragments, and what we here have is like a rim fracture of a facet joint. So pieces of the outside of the facet joint have been fractured off. It's a thing we quite often see in horses with real neck problems. Here we have a couple of images from ultrasound, and what we see here is like we come from this direction, so this is skin, muscle, then we have the joint capsule that sits here, you have a joint edge, and the joint space. So what you have here is like the synovial fold, you have the synovial membrane, the inside layer of the capsule sits here and attaches from bone to bone. This is black, is all fluid, and this is your joint capsule. This more or less like normal joints. This is a right joint, this is a left joint, and they really look similar. When we go a little bit further, you can quite often see that they get a little bit of a different shape, and sometimes the edges get a little bit more rough. What we quite often see is when we get what we call a bit modeling. In general, not really a big problem. What we quite often can see too is that this capsule gets really wide, thickened, what we call fibrosis. And what you see here on this picture with the red color, this is when we use power Doppler, and we look at blood flow very close to your joint. And what you see here is that there's a lot of blood flow very close to the joint, in your joint capsule, a very clear indication for having inflammation in that joint, or at least in your joint capsule. After having a diagnosis, we should come up with a treatment plan. And that treatment plan needs to be quite complex, and it has a certain sequence, because you need to do certain things first before you can go to the next step. For instance, our first step is always reduction of nerve symptoms and problems. You can imagine if the horse experienced electrical shocks, whatever treatment or rehab you're going to do, the horse feels miserable and is not going to work with us. So we have to fix that first. After that, we go for reduction of joint inflammation. And they have different ways for doing that. You can give oral medication, you can inject, all kind of options. We also want to have reduction of ligament and tendon inflammation if that's case. And we know for a fact from normal tendon injuries that takes long, that can take up to 6 months. When we have done all those initial treatment plan parts, we need to go for activation of core muscle action. We need to restore core muscle action to prevent it from happening again, and also for getting better support for the affected structures. You can imagine the neck has a lot of muscles, so if a certain joint has a problem and you teach the muscles around that joint to do a better job, then we have a better functioning joint again. We would like to activate the postural and kinetic musculature, meaning the muscles that keep the horse in a certain position and the muscles that make movement possible, forward, sideways, everything. And we want to get reflexes better and quicker. You can imagine without having good nerves, that's not going to work. So that's why the nerves are on top of our cascade of things to do. And then we go for increase of range of motion of the joints and the entire spine, not just in the neck, but quite often if the horse had a neck problem for a while and got stiff all over because of neck pain, you also have to take care of the rest of the spine and not just go for the neck, otherwise your effect is not going to be so good. And we have to do an adaptation of the overall condition and all the adjacent injuries and problems. Look at the whole horse and not just at the neck. As I mentioned, it's a step-by-step plan. It's individualized. Every case is different because of what kind of problems are there, so every plan is different. We have some gatekeeper moments, moments that we need to see the horse again and check if the goals are met, certain things are better, before we go on. It's based on science. It's also based on overall outcome and experience. I'm doing this now for like 30 years with looking at next cases, and I've learned which things work and which things don't. It's also based on do-it-yourself. It's easy to send the horse off to a rehab facility and have things done there, but very expensive. And for most people, not achievable because it's not in their area or it's just too expensive. Our program is really focused on do-it-yourself with riding exercises, lunging, things like that, getting the horse back into shape. And also, based on the results of over 30 years, we can tell you a nearly guaranteed outcome. Nearly all of those horses, 96% of our caseload of neck cases, go back to the original level of work. There are for sure some other options after this process when things don't work. We can go for an injection of a facet joint, even more, and we use the ultrasound and especially power Doppler ultrasound, so we know which joint is really the most inflamed. And that joint, if that doesn't react to normal medication orally, then we go for injecting that joint. That's much better than looking at an X-ray and see 5 joints with changes on the X-ray and inject those, because first, they might not be the infected joint. The ultrasound with power Doppler tells you much better which joint is really inflamed than an X-ray does. An X-ray doesn't tell you. It could be just some old damage that's not even important anymore. Also, if we inject one joint with the maximum amount of drug possible for that horse, we get a better effect and we spread that same doses over several joints. A new therapy we have is foraminectomy, what is where they drill under through scope, go into the area where there's too much bone pushing on the nerve, and then they drill that off. It's a therapy that's just in its baby stage. It starts to be done a couple of times in horses, and in my opinion, in general, what I've seen in my practice, the size of the foramen is not really the problem. It's the joint and the adjacent joint structures that are swelling that make the nerve being into a problem, not so much extra bone. But also have to realize, like when you look at a CT scan and you find a joint that's a foramen that's too small, we have to realize that the position of the neck is really important. And if the horse is a bit in a stretched position during a CT, it might look like it's smaller, while it's in real life it's not. Also, we don't have really long-time outcome results yet of the foraminectomy. From people, we know that quite often it grows back if you don't do anything. And what they do in people, quite often they stabilize the vertebrae with some pins and rods at the same time. So they make it more easy for that area not to move too much after the surgery. And that helps stay small, stay more open for that opening. And one of the last things we could do surgical is a fusion of the vertebrae, what's called the basket surgery. I don't want to go too far into it. I don't think it's for most horses very achievable because it's very expensive and very painful initially. Another option might be retirement. If horses don't really recover from neck problems, they might still have a nice life outside in the pasture. Some horses, especially when nerves are involved and they're really in pain and we cannot help them, I think human euthanasia is the final solution. And luckily, that doesn't happen often. Our rehabilitation program that is in place as soon as the horse is capable of doing things, after initially fixing a couple of problems, and is first focused on relaxation, doing stretchy exercises to open the facet joints and gently start to move them more. And then we increase the lateral motion with the circles ridden in walk, then trot, and then canter. And the circles are first big and then get smaller. You can imagine if it's a big circle, there's nearly no flexion in the neck. But when the circle gets smaller, the outside of the neck gets stretched, while the inside of the neck gets compressed a little bit. And when you bring that in very gradually, you start to improve the range of motion in joints on the outside, and you help tissue to get a bit smaller on the inside. We do that first in walk because it's very low impact, then add trot, and then add canter. We also add canter later in the rehab because when you think about the canter, when the horse lands, the head wants to go down because of the weight and the long lever of the neck. So you get a lot of muscles at that moment firing. So when you think about which gait is the best to improve muscle development in the neck, canter is the best. So as soon as the horse is capable of doing so, we put canter in the work, and it will be more and more and more. And then when that is all done, the horse returns to the original level of work. In the fastest cases, this can be a 1 or 2 month rehab and the horse is back to work. When there is more soft tissue involved, like tendons and ligaments, it might take up to 4 to 6 months. This picture shows you a lot of the stretching work that could be part of the work for horses, really stretching the neck and opening the facet joint openings so we don't damage or compress the nerves again at this moment. So that's quite often one of the first phases of rehab. It could be ridden, could be on the lunge. You can imagine with a lunge, the horse needs to really be doing that properly, because if you had to hang on the lunge to keep him on the circle, that might not be the best force for the neck. Unfortunately, there are also a couple of ways that it's not so good to do rehab for the neck, and quite often people think it's great. One of the numbers I really want to mention is carrot stretches. What you quite often get from that is hypermobility, meaning that the joint that's painful is not flexing when you ask for the stretch, and the joints next to it flex too much, and that's the last thing you want to do. Also, quite often horses are very motivated with carrot stretches to come to it, and because of that they can overdo it. The riding exercises, in my opinion, where you gently make them go sideways, are much more effective than the standing ones. Standings mean static, you just make the horse move a little bit, but the whole horse is not moving. Dynamic means that there's much more motion. When you ride, all the muscles in the whole horse work together instead of having just the muscles in the neck do some job. An example of one of those carrot stretches that people think is good for them, but is really not, and you get a lot of sideways mention. And it might be a good thing for horses that don't have a problem, but I would not advise it ever for a horse in rehab, because the motivation for the carrot here might be so much that the horse is quickly trying to bite it and then come back. It's a far too abrupt motion for a joint. Much better is gently stretching and making it stretch again, come straight again, stretching, straight again, stretching, straight again, like what we could do in riding. Some people advocate tape for work in rehab in the neck, and then they tape the whole neck. The problem is that when you tape, quite often initially it might work because they give a different signal to certain muscle groups, but in several minutes you get an adaptation and the tape just sits there and the horse doesn't really react to it anymore. Some examples of taping for the neck and the shoulder region. We have to realize that it all looks fancy with those collars, but there is nearly no any research really supporting this. It's more people doing this from experience and say it works. What for science is not enough to accept it as something that works. There are a couple of fancy methods to do things. Electrotherapy, functional electrical stimulation, or TENS. What we need to realize with that is that you take over the function of the nerve, so you make a muscle work, that's great, but you don't fix the nerve itself. So there are some cases it might work, especially when you want to re-innervate a nerve that has been damaged so much that you need to take over the function of the nerve for a while and then hope that the nerve starts to do it again. But it's very specialistic and for sure not a thing we do often. Here you see a picture of those, the two electrodes, the muscle group in between will get a signal every time there's a little power electrical flow through those pads, and the muscle starts to work. And sometimes you can really see it start to move, and in cases you really want to keep a muscle in good shape, waiting for a nerve to come back to do function, then this might work. A question we often get is, how do they get it? How has a horse coming into a neck problem? Well, often it's conformation. Certain horses just have a shape in their neck that makes it easier for them to get problems than others. But there's so many things. Playing with another horse, really rough, overstretching the neck more than they should. Falling is a good one. We see a lot of horses here in the Midwest in summer that chasing flies away during the day constantly with very fast motions of their neck, what quite often can finally set up a problem. There's some riding techniques, especially when you see the deep and low or flexing the neck really sideways. We see a clear correlation with neck problems later. Often it starts with a small swelling of the soft tissue of one of the joints. That joints get stretched a little bit too far, it reacts with a little bit more fluid, like when you twist your ankle. But the problem is we don't see that. The horse doesn't really show pain or not clear pain. We don't recognize it, and we go on. And the joint over time gets bigger and bigger. The tissue changes. Quite often the capsule gets a bit thicker to compensate for the stretching of the capsule. And at a certain moment it reaches a trigger point when it starts to irritate the nerve. And that could be a couple of days away from the initial injury, but sometimes half a year or a year. So it's sometimes very difficult to figure out what exactly set off the problem. A very common problem we see in our practice is the hypermobility horse. The young horse that's extremely athletic, extremely flexible, and wants to really do a lot of work and has a lot of energy. But in general, when they're younger, they're not so well muscled, and quite often they're not so very well conditioned. So when they overdo it and overflex their neck because they're so busy and they have such an amazing neck and so much a range of motion, that's quite often the first time when they overstretch a joint, and then the whole process can start. And here an example of a younger horse, not very well muscled, very athletic, very flexible, playing in the field. That's why he has the bell boots on to not pull off his front shoes, but he should maybe also have a brace around his neck to prevent him from doing stupid things. And it's just common, it happens. And if you recognize it early, it's an easy fix to make the joint stop being swelling and you go back, be swollen, and you go back to where it was before. This horse shows you a nice developed neck, but when you look a bit at the lower part of the neck, you can still see that the muscles are not as well defined as on the top of the neck. So when this horse starts working, I would say the top of the neck is ready for the work, but the lower part connected to the shoulder is maybe where you can easily overflex. And that's why we quite see often when horses do have problems, it's very often in the C5, C6, C7 region and nearly never higher up. And this picture of two horses really being nice together, and maybe the moment later they're going to have a little play, you can see how flexible that neck of the horse on the left is, but also how not much muscle it at this moment still has. So it's very easy to be busy, overflex joints, and start neck issues. Yeah, and some horses, just based on the conformation, based on their breed, they are just really predisposed for getting problems. This picture of a full-grown trained horse shows you a well-developed neck, well-developed hind end. This horse is Pharaoh, that was 5th at the World Games in Rome and went to the Olympics. So those horses, because of their very strong muscularization, are less likely to get injuries in their neck. And this is a picture of my own horse. At this picture, he's 22 years old. He's performing at the Grand Prix level, going to national and regional championships. And you can also see a quite well-developed neck, but also a quite well-developed hind end. So the whole horse proportional has a nice muscularization that takes quite some time. But when they have this, it's far less likely they get injured. So he got at the age of 22 without ever having a real injury during his entire life. So what we could do for the young athlete to not or had less chances of getting the neck injuries, realize it takes 3 to 6 years to fully develop. When you look at the filling in of the growth plates in the neck vertebrae, that quite often happens only at 5 to 6 years old. So we have to be careful using them too much when they're young or doing too much with them. Vitamin E supplementation might be really important when horses are not out all day and eating enough grass, but has plenty of vitamin E. So quite often when winter is there is no grass and they only eat hay, vitamin E supplementation might be necessary. And I would advise to take blood samples regularly to check that. We want to adapt a work program that develops muscles, especially the muscles of the neck, And as we mentioned, that's just a lot of canter. And quite often in the younger horse we don't do that too much because we think it's damaging them. But I think we can early on start doing some normal canter work, much better than doing all kinds of fancy things in lateral gaits. The most important thing is that we don't want to get them too much work so they get too fatigued. When the muscle gets tired, it doesn't have the normal power anymore, and that's the moment when the horse makes a misstep. A tissue is extended and stretched too far because the muscles don't protect it, and that's the beginning of a problem. So we get a lot of shorter episodes of work and give the horse some time to relax in between. Variation, not every day the same, but do different things. That will first trigger different muscle groups to do a different thing. It also avoid repetitive stress injuries where we do the same thing to the same tissue over and over and over again. And for the younger athlete, no crazy exercises, no passage in piaffe, no crazy lateral gaits yet. Just bring them up with the neck in mind. And you need some assistance with that, with a good trainer, a good vet, a saddle fitter, a physiotherapist, and so on. We quite often cannot do this by ourselves. We need a team of people to help us to do this properly. I hope you enjoyed this video and get a lot of knowledge from it. If you have questions, you can put them in the comments under the YouTube video, and hopefully we have some time to answer them. Realize general questions, not a question from your horse, what you should do you in your position, because as I mentioned before, it is a whole exam and a whole bunch of diagnostic tools before you know what's going on and before I can give a good advice. It's not helpful for you if I give some general advice that's not based on anything on your horse, but more general advice. Good luck.